This presentation is part 2 of the ACL risk and rehab assignment. Our group was Michael, Katie, Tianna, Rebekah, and Magan. We'll be talking about an ACL reconstruction post-surgery protocol today. But first, a bit about our patient. We decided she was a female collegiate Division I basketball player. She was 19 years old. She had a classic non-contact mechanism of injury, and the surgery she had was a bone patellar tendon bone autograft ACL reconstruction. So first we'll just go through the phases and details about each phase, and then we'll go through example rehabilitation days from those phases. So phase 1, the timeline is from day of surgery up until the end of week 4. The goals of phase 1 are to gain full knee extension and to achieve trace to no knee effusion, so barely any swelling, if any. We want to achieve quadriceps neuromuscular control and activation as well. And risk for this phase are infection of the wound of the surgery site and re-tearing of that ACL, so tearing of the graft they put in. To progress on to phase 2, for clinical signs, we want to have, like we said, trace to no effusion in the knee. We want full active knee extension and 120 degrees of knee flexion. For neuromuscular control, we want them to be able to hold terminal knee extension on a single leg weight bearing and normalize gait without the use of crutches, and to perform a straight leg raise with no quadriceps lag. For psychological factors, we want them to be emotionally prepared to begin phase 2 and resisted strength exercises. For phase 2, the timeline is from week 5 up until the end of month 4. The goals for phase 2 are to regain single leg balance and neuromuscular control and regain muscular strength. And one task is a single leg squat with good control. Some risks for phase 2 are development of false confidence due to progression and rehabilitation. So what that means is they're getting really good at their rehab. They think they're, good to go back to sport, and they do something or many things a little too quickly and before their knee is ready for that. In order to progress on to phase 3, for clinical signs, like we said, we want no effusion in the knee. And for phase 2, we want full active knee range of motion, so flexion and extension, when compared bilaterally. For neuromuscular control, we want greater than 80% of each of the following: limb symmetry for a single leg squat, quadriceps strength symmetry, and symmetry on the hop test with adequate movement quality. Phase 3, the timeline is from month 5 up until either month 9 or month 12. That kind of depends on the athlete, what their sport is, so ours might take a little bit longer because there's a lot of cutting in basketball. But the athlete could progress really fast and do really well with their rehab, so it depends on the athlete and the physician. Goals for phase 3 are to regain full strength and balance, maintain and build athletic confidence, and progress sport-specific skills from closed skills with an internal focus to more open skills with an external focus. And risk during phase 3 are a fear of returning to sport and anxiety due to social demands and expectations from coach and teammate. So again, that's feeling like their teammates and their coach needs them to return to the team activities and return to the sport faster. Maybe they're getting to the end of their season or something. So they're feeling really nervous about, if I don't get back, coach won't play me, or, things like that. In order to progress to fully return to sport out of phase 3, the clinical signs are no functional instability, no effusion, again, full knee range of motion when compared bilaterally, and pain-free and sport-specific tasks. So they need to be doing their sport-specific activities well to be able to return to sport. And have no feelings of instability. For neuromuscular control, we want greater than 95% limb symmetry in each of the following: single leg squat, isokinetic quadriceps and hamstring strength, and single leg hop test with good movement quality. We also want good movement quality during field training and sport-specific tasks, which can be sort of a judgment based on the athletic trainer, and some coaches' input is helpful during sport-specific tasks and things like, are they having good form when they're guarding, or things like that. One more thing to progress out of phase 3 are psychological factors. We want them to be confident in their field training and sport-specific tasks, and we're going to measure the psychological readiness with the ACL RSI, which is a readiness to return to sport patient-reported outcome measure. So now we're going to go through different examples of rehabilitation days. So it'll be phase 1, 2, and 3. For phase 1, like we said, that's 0 to 4 weeks post-op. We want to increase range of motion and reduce swelling. And the criteria to progress include knee return to full extension, so 0 degrees, knee flexion at 120 degrees, and then we want them to be out of the knee immobilizer as well. So these are the exercises that we're going to go through with their sets and reps, but I'll talk a little bit more in detail. First is patellar glides, so it's going to be 20 times each way just to get enough motion within the patella, and it kind of helps move the swelling out as well. So the purpose is to increase mobility of the patella and assist in knee range of motion. There's not really any progressions or regressions of this, just we're going to do it until they have good movement of the patella. Next is going to be ankle pumps on the wall. We're going to do 50 times. So one time is plantar flexion and dorsiflexion. This just helps with reducing edema in the knee, so we're using that muscle pump in addition to gravity to kind of pull all of the fluid back out of the knee and into the body. Next will be quad sets with the heel propped up. We want to have the heel propped up just to help them get into knee extension. We're going to have them do 50 quad sets because we just need enough to get them to activate their quad and to know what activating their quad really feels like. So the purpose of the exercise, like I said, is quad strengthening and assisting in knee extension, so really getting active knee extension. For progression, we're going to do mini squats with an exaggerated contraction of the quad, and regression will add stim onto the quad sets to help them fire that muscle if they're having trouble. Next will be seated leg extensions. We'll do 3 times 10 of those. And this just, again, helps increase knee extension and assist in quad strength. So we're working on the quad just in a slightly different way. A progression could be a leg extension machine, increasing those reps. And regression can be prone hangs if they're having trouble getting that extension on their own. And assist with the other foot, as you can see in the video. Next will be heel slides. We're going to do 50 of those, again, to just work on our flexion. The more reps we have, the better off we'll be. The purpose of the exercise is to get that knee flexion back. So some progression that we can do is adding ankle weights, and again, progressing to those mini squats, a more weight-bearing position. To regress, we can do towel band assisted heel slides like we see in the video, or we can do up the wall to have gravity assist the heel slide as well. Next will be straight leg raises. This helps increase strength of the knee and the hip muscles. So once again, we're working on knee extension and activation of the quad in addition to those hip flexors. So we can progress with ankle weights or a band. And regression would be clinician assisted, so the clinician helps lift up the foot a little bit, or the patient can hold on to a band and kind of pull their leg up. The next will be banded clamshells. So this strengthens the abductor and adductor muscles. So progression will be to the abduction and adduction leg machine, or standing hip abduction and adduction. And then a regression is shown in the video, so it'll be clamshells without the band, just to get that feel of firing the correct abductors. Next is terminal knee extension. Once again, we're working on knee extension and really firing the quad. As you can see, that's really the goal. The biggest goal of this phase is to get quad activation back. So progression can be increasing the band resistance, or even going to a single leg. And then a regression, similar to the knee extensions, is going to be a prone hang, just to try to like gravity pull the knee into extension. Next will be double leg calf raises. This increases strength in the gastroc and improve balance. Some progressions can be single leg, on a slant board, on an AirX pad, or eccentric. And then regression can be table or clinician assisted. So as you can see in the video, I'm kind of holding onto the table to help keep my balance, to help keep some of the pressure off of my leg if weight bearing is still hard for the patient. And then just some modalities that we can use during phase 1. If we want to do E-stem for pain control, we'll use a perimeter seen here on the screen, or we can use it to increase quad contraction in the VMO, as we see here. We can also use a game ready for cryotherapy, and we're only going to use that after rehab has been completed for pain control. Moving on to the phase 2 example day. Like before, here are the exercises listed out that we'll do with their associated reps. So first we'll have the supine four-way hip. This is increased activation of the main muscles of the hip and improve hip mobility and increasing core strength. So even though we're like focusing on their knee rehab, we want to look at the joints above and below. So we were looking at the ankle joint in the last exercise, and now we're going to look at the hip and really get those hip muscles moving and strengthening. To progress, we can have them do the exercise on an uneven surface, so progress to standing. And then regression, as the clinician, can help lift the hip up to get that range of motion. So here's the video. You'll see it in all 4 directions. Next is the mini squats with the TheraBand. So we mentioned that this could be a progression of our phase 1 exercises. So here it is. We want to increase the range of motion in the knees, hips, and the ankles. And it can also help incorporate activities of daily living, like climbing stairs or getting up out of a chair, things like that. So progression will be full body weight squats, so lowering the hips even closer to the floor. And regression can be adding a heel lift underneath the patient to reduce pain in the knee. So if they're having that, we can just give them a little bit more relief. Again, here's the video. We want to make sure they're not collapsing into valgus to avoid stress on the new ACL. Next, we have hamstring curls on the ball. This strengthens the knee flexors, the hamstrings. It also helps with core stability and mimics the action of running. So we need to have them achieve that knee flexion so that when they're running down the core and when they're jumping, like they really have the knee flexion strength to do all of those activities. So progression can be Nordic curls. A regression can be if the patient is supine and just does simple glute bridges. So it could be glute bridges on the ball, like the video will show, or just simple glute bridges on the table. So here's that video. You'll see she starts with glute bridges on the ball and then progresses to the hamstring curls on the ball. Next we have Bosu ball balance. So this increases neuromuscular control and proprioception, which is super important, especially in basketball, because people are moving around us all the time in basketball. So we're going to have the athlete balance on the Bosu while doing a chest pass, and then they can progress that to increase them to dribbling while on the Bosu. And a progression can be balancing on an even surface, so the floor, or regress to an RX pad even. So here's an example. You'll see she'll start with the chest pass while on the Bosu, and then we'll progress to dribbling. Ideally, we'll choose an actual basketball from the team. We didn't have access to that for these videos, so that's why we'll be using the physio ball in any dribbling activities. Next, we have box jumps. This introduces plyometrics into the rehab protocol. It's also going to increase cardiovascular endurance because it's a more cardiovascularly intense exercise. It's going to help us with explosiveness for jumping and dunking perhaps, or just regular shooting and blocking within basketball close to the net. And then in addition to coordination and stability, a progression can be depth jumps, and then regression is simple step-ups. So here's a video of box jumps. For modalities during phase 2, we can do cryotherapy as needed, just to help with pain, and we can do some elevation to help with swelling. Again, we can add compression to help with swelling. If you need to continue with electrical stimulation, we can add that. We can also add in BFR to just get increased workload out of our low weight exercises. And then if we need any analgesics, still we can include that. So this is what an example day of phase 3 will look like. The first exercise will be a layup on a step-up board. So we'll do 3 sets of 20 just to get a lot of repetitions in and work on muscular endurance in this pattern, since layup is a common shot in basketball. We want to practice jumping, practice safe landing, and retraining the body to remember the proper layup form. For progression, we can add a resistance band around the legs or make the step higher. And for regression, we can take away the board and just work on the motion, or regress to double leg jumping and landing. So for sport specificity, we're talking about the layup form here. Here's the video of that exercise as an example. Next, we have single leg balance on an unstable surface while passing the ball. We'll do 4 sets of 30 seconds just to get enough balance to hit proprioception. Like I mentioned, the purpose of the exercise is to work on proprioception and also add in a little bit of neuroplasticity related to gameplay. So we want to progress it by making the passes faster or adding even a second ball, a second passer coming from different directions. To regress, we can take away the unstable surface or regress to an RX pad, or we can include not passing a ball, so just regular single leg balance. For sport specificity, we're talking about hand-eye coordination and passing. Here's a video of what that will look like. So this is single leg with the ball passing. Next, we have cone drills with dribbling. So we're going to do 5 sets of each and make sure the straight cone cutting drill and square cone cutting drill. So in total, we'll have 10. The purpose of this exercise is to replicate a game-like movement and to determine ability of play effectively. So to progress, we'll add passing or apply a strobe or prism glasses to interrupt the visual input, and add a little neuroplasticity in there as well. And then to regress, we'll take the ball away and just practice the movement pattern of the body. So this is sport specific because it includes those movements, the side shuffle and sprints, and includes dribbling practice. Again, we don't have a basketball in our clinic, so we use this ball, but ideally we'll use a basketball from the team. Next, we have ladders with passing. So we'll have 4 supersets of each type of the ladder. Agility exercise. So we're working on improving speed and agility in addition to hand-eye coordination. So we'll progress by increasing the speed or increasing the passing speed, and regress by decreasing those things or taking away the passing aspect of the exercise. Again, this is similar agility that is included in basketball and the passing drills that are included in basketball. Here's a video of that. For modalities, we can use electrical stimulation for desensitization and daily pain management if they're still having pain, if that's something they like to do. Same with Game Ready for cryotherapy and compression, and if we use that, we would do right after our exercises. We can also use the Venus Heal, which uses pulse magnetic energy to massage and deeply heat tissues, and then same thing with laser to heat those deeper tissues. So now we're going to look at some neuroplastic exercises for our rehab program. These would be added into the later phases, so probably phase 3 of our program, just because they're a bit more difficult. So the first one is ARX pad jumps. So the patient's going to be doing a single leg jump off an ARX pad, and the clinician gets to decide if the patient is landing back on the ARX pad or if they're landing on the floor. So the patient doesn't know which surface they will be landing on. We're going to do 3 sets of 20 reps of each leg, particularly on the ACL reconstructed leg, just because we need more than the typical 15 to 45 reps for neuroplasticity to take effect. And the volume more closely replicates how many reps they'll do during practice or during a game. So we're using this to increase the neuroplasticity during sport-specific movement, and we want to do that by placing attention on the game or on the jump itself rather than on the patient's knee. So here's a video of that. As you can see, he's landing differently on the ARX pad than on the floor. He doesn't know which surface he's going to get. To progress this, we can have the patient close their eyes so they really don't know what surface they're landing on, or we could add in a pass from the patient. This will be with eyes open, to a certain direction upon landing. So say they jump up, you say pass to person number 3, and so then they'll pass the ball to that 3 position on the court. To regress, we'll take away the ARX pad, so we can first take it away upon landing, so they're landing on the floor every time. We could take it away upon the takeoff, so they're just jumping off from the floor. Or we could regress it to double leg jumps. And this is very sport specific due to the jumping for layups. It kind of mimics that pattern, especially moving on from what we did in our phase 3 exercises. And it strengthens the knee and the ankle in a dynamic way. So cutting, landing on other players, things like that. and then practice with landing and passing. The other neuroplastic exercise we have is a Bosu side shuffle. So they're going to continuously side shuffle with a Bosu either at one or both ends, depending on the resources. The clinician will decide when to say go, and whenever that is, the patient will take off into a sprint. Again, we're going to do more than the typical 15 to 45 reps for neuroplasticity to take effect, so we'll do 4 sets of 12. Also, lots of side shuffling targets the cardiovascular system, so we're getting them back up to the cardiovascular needs of their sport. Side shuffling targets resisting against valgus force as well, so we want them to be strong against valgus forces since that's what likely caused the ACL tear. And then cutting and working with variable surface increases the dynamic ability during defense and other offensive plays that the team has. Here's a video of that. As you can see, she's going, she's getting tired. She added a dribbling just to have a sport-specific task. So to progress this, we can say have the patient sprint whenever the ball is passed to them. So rather than go, you just run when the ball is passed to them. And then we can add in a pass to a specific position number, like I said before. Like if we say pass to number 2, they'll pass to the person in the 2 spot. And to regress it, we can have them sprint after a predetermined number of side shuffles. So say we do 4 and then sprint, or we can take away the Bosu ball using the RX pad or just the floor to take away the unstable surface. Side shuffling and cutting to sprint occurs a lot in both offensive plays and defense during basketball, like when they're switching with another player in a defensive play, or they're shooting to score and then they sprint down the court in transition. And lastly, here are the references we used. I know that was long, so I'm going to say thank you for listening.